This is a presentation of the case, 73 years old female, right-handed, history of high blood pressure, hemochromatosis. She has some balance disturbances, and she was found with an incidental, on an incidental MR, an unruptured non-thrombosed right internal carotid artery aneurysm. So this is the angiogram that was performed. Supraclinoid carotid artery aneurysm, which has nothing specific. You will see the neck on the 3D, checking the posterior circulation, understanding the potential PCOM. Here there is no. This is this is the 3D pictures. You can understand the neck. You can understand the relationships with the carotid, with the ophthalmic artery, which is not included in the sac of the aneurysm, nor in the neck. There are several blebs, like here, for example, but nothing very sophisticated. So this is a measurement, size of the carotid, size of the sac, which is important and not important at the same time, because we are going to treat it with a flow diverter without any coils in the sac, but nevertheless, it's part of the screening of the aneurysm. So this is the other view, looking from above. It's not that large, but it's a pretty large aneurysm. Several measurements. Sizing of the carotid, 4.7 up to 3.7, which is pretty much what we usually find. So the treatment is going to be done with a long sheet. It's going to be an infinity. The guiding catheter is a Catalyst 5 French. So we are always trying to make something which is homogeneous with the company. So everything, as much as possible, belongs to the same company, Stryker. The microcatheter is going to be an XT27. The microguide wire is a Synchro 14. And the stent which is going to be used is a new flow diverter from Stryker, whose name is EVOLVE. Well, so this is, the purpose of the treatment, which is not that much. So the sizing simulation that was done using the Siemens Cure technology. Oh, it's gone. Okay, so the Siemens Cure will be done directly from the angio suite. There was a mistake in the...
Jacques, can you hear me in the Louvre?
Oui, oui.
Oui, oui. Okay, so good morning, everybody. So we have been preparing the case in the meantime. So you may have on the screen the 3D acquisition, which was performed. So this is a carotid siphon aneurysm. Not something very specific. This is the ophthalmic artery. This is the anterior choroidal artery. So we will try to not cover the anterior choroidal artery with the flow diverter, even we don't care too much. So for you to understand, we have selected two views. The first one will be that one just to cross the neck of the aneurysm. We'll be using the 3D roadmap. And the second one will be that one just to clearly view the M1 segment and especially the MCA bifurcation. So the aneurysm, the measurement of the aneurysm is roughly 9 millimeters, so we don't plan to put any coils inside. As you can see on this aneurysm, there is a small daughter sac here. So we did the 3D roadmap and transferred it automatically. We have sent it automatically to the LINNC software directly, so probably you can see it on screen. Can you send the simulation? So you see here the software. So most of you know already. So you can choose whatever is the brand. So this is an EVOLVE, which is the new flow diverter from Stryker. And you can select the diameter. We have selected the 4.5 diameter. And just for you to give an example, this is a 17. This is a 17. So here you clearly see here the wall position. So as far as it is green, then you get a very good wall position, especially distally and proximally. Of course, you don't have a proper wall position at the level of the neck. This is normal because there is no constraint for the flow diverter. So we placed it proximal to the anterior carotid artery. You can have it shorter, and automatically the flow diverter will simulate where you should have the landing position. Of course, it's a braided stent, so you may have a different kind of push. So this is an average push. So if you are willing to push more, you can. It's a 20% push. You can push more, and then of course you will shorten the flow diverter. So I will use the normal push, which is around 20%. I will keep an eye on this simulation. Just to be sure where I will be landing. So this will be all the things that we'll be doing. So we'll be using the XT27 with the Synchro 14 just to put in place the EVOLVE flow diverter. So now I will do it. Jacques, can you manage now the comment, please?
Okay. So you understood how we manage with the LINNC. If you are lucky enough to have this program incorporated to your angio suite, it's really easy to use and very convenient and gives a very informative result. We like to play, especially for the flow diverter and the aneurysm, with the 3D roadmap.
I have one question.
You use it more and more, the 3D roadmap, Jack?
No, it's not more and more. It's routine practice. Routine.
I have one question for the faculty. You know, Laurent says that he will not place coils in aneurysm according to the size. I don't see too much the reason not to place 2 or 3 coils. It's more or less 10 millimeter aneurysm. I will personally place coils. I don't know what you will do, but...
I would not place coils. I think the literature on an asymptomatic aneurysm at 10 millimeters is extremely benign. So I also am not sure that the 2 or 3 coils do anything for you. Maybe it helps you sleep at night better.
I agree, but you know, it's the only time you will be able to place coils in aneurysm after deployment of the flow diverter. It's finished. So.
No, but you know, there are 2 different situations. The first one is the ophthalmic artery is arising from the neck of the aneurysm and entertaining the flow. And this case, where there is absolutely no relationships between the ophthalmic and the aneurysm, so honestly, I don't think it's necessary to put coils in the sac. If the ophthalmic artery is involved, I think it's good to put coils and even to occlude the origin of the ophthalmic to avoid any potential complication.
do you ever study the internal maxillary artery to see the ophthalmic feeling from the internal maxillary?
No, it always exists. A long time ago we did, but now we don't.
Okay.
No, you do it, Alex. There is no reason to do it.
So if it's possible, maybe you can...
You are not sure you will see something, even if there is an anastomosis.
Well, I mean, I'm just showing my age.
You may have an anastomosis which is not visible because it's coming from in the normal direction of flow. No,
Yeah.
no, it's a question for you.
No, I mean, but if you know that you have a collateral coming and feeling the ophthalmic, if you put coils in and close the ophthalmic to protect distal emboli, you can make that argument.
Yeah. But if you want to see if the ophthalmic is filled by the maxillary artery, you have to do an occlusion test, by the way.
Not always.
Otherwise,
You can use higher volume, 2 or 3 second injection. Usually, you see it.
Okay.
So it's a routine stent positioning, navigation of the catheter over the wire, crossing the neck. A good support from the guiding catheter. And then again, you have 2 different ways of delivering the flow diverter, compression or stretching. So the stent is an EVOLVE, the new one from Stryker. It's a 4.5 by 17.
Jacques, correct me if I'm wrong, but previously it was a common practice to get the distal access catheter like CAT5 itself cross the aneurysm and then get your delivery catheter through it. And so this is the new generation which probably circumvents
coiling or push to stent to prevent the premature rupture. Which will you like?
No, usually when the sac of the aneurysm is not over 15 millimeter, we don't put coils in the sac.
Okay.
Unless the ophthalmic artery is really involved in the sac itself, because it keeps the flow through it. So we'll probably see the stent coming. It's a straightforward anatomy.
See that, with the 3D roadmap, you see how, because you obtained it before you put the catheter and guide wires, it seems to be a mismatch. So Jack, he extruded a little bit and then brought it back.
Okay, he's trying to fix the best view to understand where he's going to land. So again, as you can see, the stent was not deployed distally, pull up to the point. The stent is not deployed at all, just the little extremity, and then it will be delivered right at the position on compression. The beauty of using the 3D is just to help you to understand what is the best view to clearly fix the landing zone of the distal part of the stent. is using the electronic zoom. As you can see on the side, on the left side of the screen, everything is controlled by the tablets. It's like a smartphone. Huh? You select, you recall the view, you change the runs, you fix your smart mask. So you see the stent is not deployed completely. Laurent is trying to avoid covering the origin of the choroidal artery, which is in that case something, if you can do it, you better do it. If you cannot, you don't do it. But here you have quite a bit of space. Turning around the carotid siphon and extending the distal part of the carotid artery is really a good way. So he understood the right position to see where is the landing zone. So we have this, and the neck is already there. So if you start here, it's going to be a good way. The stent was chosen has a quite short one. It's only 17 millimeter. And we clearly realign on the measurement of the Simon curve. And we also clearly realize on the fact that when you deliver the stent in compression, you have a much better control of the length of the delivery because you don't deform the stent when you deploy it. So you see the selection of the position on the 3D roadmap, then it goes directly to the gantry. And now we start the deployment of the stent. Once you are here, you just have to push on the stent and the catheter is resisting, but push back, open the stent. You don't need to pull on the catheter, you just pull on the stent, push on the stent. So the distal part of the stent is there. So in the meantime, Laurent is finishing the deployment. We can start answering the question on the screen. You spare the choroidal artery because in your experience you had some trouble. The answer is no. But if you can avoid covering the anterior choroidal artery without taking any risk, why not? It's always better. You never know what can happen. Medicine is never 100%, so you never know. The presence of intracellular thrombosis change your choice to coil or not. The answer to us is no. It doesn't change the concern, except if it's a real giant partially thrombosed aneurysm. As giant partially thrombosed or not partially thrombosed, we definitely prefer to coils in 1 or 2 sessions and then to put a flow diverter because we have a lot of risk to lose the control of the proteolytic enzyme release and the vasorum and then to get bleeding of the aneurysm. You will see one of the cases we did last year. You will see the follow-up. A few weeks after the treatment, the patient got bleeding from the sac, and it was a non-thrombosed aneurysm in which we delivered some coils, and we had another stent. She got 2 flow diverter, but despite that, she got a bleed a few weeks later. Can the stimulation help to choose the strategy, coil, stent only? No, it helps you to measure and take the right choice of the material you are using. The strategy belongs to the doctor, thanks to for the time being, because we never know what's going to happen in 20 years from now. We are still responsible of the strategy. The machine doesn't take the decision in our name. So I think it's definitely a good way to continue. So now the stent is almost completely decided. This is the recapture marker. If you pass that, then you cannot recapture the stent. But as far as the stent is in a good position, now it's completely open at the level of the curve. We can clearly see on the fluoroscopy that the stent is deployed. Nevertheless, it's always a good point to do the control when the catheter is still in position. Okay, if you look at this, if you look at the control angiogram here, you have the stent, you have the position of the proximal part of the stent, which is not under your control. You have the control of the distal, but not the control of the proximal. But with the Siemens cure, you have the control of the proximal part. So you can see that we are pretty much the same, So this one is a little bit covering the anterior choroidal. This one is not at all. So if you balance the distal part and the proximal part, we are exactly at the same level. So we do vaso-CT to understand the stepwise effect at the level of the curve. If it's too much stepwise effect, then we like to do another one to smoothen the apposition of the stent according to the vessel itself. So the vaso-CT is going to be performed. We have a very good view of. As you can see, the vaso-CT is performed with the microcatheter in the position in case we have to, or we decide to deliver another one to smoothen the stepwise effect here. We don't necessarily need to leave it. Okay, so they do the vaso-CT, they make a flow study. The patient had, before the treatment of the aneurysm, the patient had a flow study, and now we will compare the flow study before and after the delivery of the stent. So the time they do that, we are free to open the discussion. Okay, so who is using flow studies and who is taking care of the information given by your flow study? Nobody? Flow studies? Nobody. In the audience? In the audience? In the audience? Nobody.
Jacques, we are doing a flow study, but it doesn't work. It didn't work, so we stopped.
Okay. It doesn't work. What does that mean? So it doesn't give any information. It works, but it doesn't give any information.
The reproducibility is very difficult. If we check twice, the data is different. So I can rely on the reproducibility of the data.
The big concern with the flow study when you put a flow diverter is 98% of the cases are cured whatever you do. So, it's pretty much, trying to depict the 2% of cases that are not going to work. It's not too much a big deal. If it doesn't work after the first one, you deliver another one 3 months later or 5, 6 months later, and that's it. So I totally agree. Is somebody foreseeing a future for this flow study? Even Fadi Charbel, who is the king of the flow study, he's not too much optimistic. Huh?
No, I think that for occlusion of the aneurysm, you're right. You're absolutely right. If it doesn't work, you can put another one. Where I think it might be of interest, but the problem has already been stated, is the concern of compromise of branching points. Can we reliably simulate that? Or downstream effect of flow. The problem with this is that it's really very difficult at this point to provide data that correlates with clinical findings. We just can't do that. I mean, we can try, it always looks beautiful, you can show great pictures, nice colors, all looks good, but useful? No.
That's exactly what we are going to do. We are going to show nice picture, nice colors, nice vectors. Science, it looks scientific, really scientific, but what doesn't bring, it's pretty much difficult to clarify.
Yeah, flow simulation had problem that you don't simulate the endothelium effect. You don't simulation the coagulation, and the blood it's a adhesive liquid. So if you use a simulation, you only simulate the flow. Lots of factors you don't consider, so it doesn't work that way.
No, we do understand, but the purpose is to compare immediately after the deposition, and the modification of the flow that has been induced by the delivery of the flow diverter is immediately characterized. And the MAFA. So if the MAFA is below 1, it's good. If the MAFA is above 1, you have a chance that the aneurysm will not thrombose. But it's a very small chance. It's only 2%. So
Jacques, let's say that's the point. Is you will not change your strategy of treatment due to the flow study, or will you? For example, if there is not an important modification of the flow in the aneurysm, will you put a second flow diverter, for example?
The answer is no.
Oh, yes. Me too. I will do the same. So I will put a flow diverter and I will wait on in 90, I don't know how many, % of cases, aneurysm will be occluded at 6 months or 1 year. So.
But it's interesting because we are more and more mature regarding this flow study, and we clearly understand today that it's not really useful. Will it be useful one day? I don't know.
I agree with you.
Maybe the treatment of the aneurysm is going to change. What we do today is probably rough and brutal and whatever. If it changes, why not? Suppose the treatment of the aneurysm becomes a medical treatment.
Yeah.
So maybe it's important to understand what's going to be the flow in the modification according to time of the aneurysm. I don't know. There is maybe something in the future, but for the time being, we clearly don't see too much the influence of that.
For a scientific purpose, you're right, but for a clinical purpose, I think as of now, we don't need it really. Yeah, but.
Absolutely. So they are doing the flow study, and we will show you the result of the flow study in a very short period of time. Okay, we still have 2 minutes for discussion before he gives the information regarding the flow study. Any special question or burning question for this case, for all kind of case, for carotid ophthalmic aneurysm, influences of ophthalmic artery versus the neck?
I have a question for Fadi. Seeing what are the results of flow diversion, do you think and do you agree that today that's the treatment of choice for paraclinoid aneurysms, or?
No, no doubt about it. I mean, it is the treatment of choice.
For every kind of paraclinoid aneurysm, or depending on the size?
No, I think any of these aneurysms that come from non-branching points, in my opinion, are straightforward, should be treated with a flow diverter.
Now, there is I think we all agree that truly giant symptomatic paraclinode aneurysms, flow diverter, still there are important complications. That's the kind of case where I think that an alternative solution today might have a significance if can be offered with because the data that we have when we deal with the truly symptomatic giant greater than 2.5 millimeters, those are the ones where the rebleeding rate, 2.5 centimeter, the bleeding rate, it's still in the over 10%.
Well, I mean, that's an interesting point. The problem, though, is that this occurs it can also occur in aneurysms that are treated with surgical flow diversion, say a bypass and distal occlusion or proximal occlusion. The reason you talk about it more is because you've done a lot more flow diversions for giant aneurysms. As it turns out, we just published a paper of 5 cases from multiple centers. It does happen. I think the physiology of an aneurysm rupturing, large aneurysm rupturing, after you disturb flow in it or you divert flow around from it, is the same. It's not an inherent property of the stent. It's just a problem of changing the flow in it. So it happens either way. So with these large aneurysms, you either have to completely interrupt the flow in them or that risks exist no matter what you do.
Okay, so we are back to be set. We have to finish with this study, and Laurent is going to show the flow study and the result.
Jacques, can you hear me?
Yes.
Okay? So this is the result of the VASO-CT. So we just double-check that the EVOLVE is properly applied. So this is the distal apposition of the EVOLVE. Of course, there is a compression at the level of the neck. And most important is the apposition at the level of the carotid siphon. So I turn around. I will get a thinner slice. So this is the view. The view, I will go back and forth. Okay.
Sticking out.
So I will show you also the flow study. Ah bah là, j'ai pas l'extravision 2. Vous pouvez envoyer l'extravision 2, moi j'ai pas la main.
Pretty.
C'est bon là.
Okay, you may see but it's cropped probably, so you don't see the MAFA calculation, unfortunately. What I see is that you don't have the MAFA calculation. If somebody can tell me the MAFA calculation, please.
Would you compare this study to
So the MAFA is 0.61. 0.61, so it's below 1. So as you can see, probably it's a little bit cropped on the right-hand side. You have a huge decrease in the flow in the aneurysm, 0.61. So normally when it's less than 1, you have quite a kind of arguments to foresee that you will have a delayed thrombosis of the aneurysm.
Okay.
So you see here the acquisition of the final CT, which is also belonging to our protocol. So this is the butterfly movement, as you can see. So the gantry is circling in a complex movement around the head of the patient to decrease the artifact for the CT. So you see now the reconstruction of the CT using the butterfly. It's come in a second. So here we are. So this is the protocols that we are using to assess there is no bleeding, especially when the patient is under double antiplatelet therapy. So especially at the level of the posterior fossa, there is a huge decrease in the artifact. Okay, that's finished for us.
Thank you. Coffee break.
Coffee break? Oh, bah, c'est sûr.
How can you beat this?
L'oiseau roi couronné portait un diamant bleu.